All right, so this is a course on history. As you know, the beginning of the course started out with Alaska Award, and it had a sort of a theme that goes through history. So the theme that goes through history is, in essence, it's a team approach. So there's a clinician that was involved, a scientist, and the patient. Nowadays, the clinician, audiologist, scientist might be represented by the company. If you look at the physician, he's going to be the actual clinician, and the patient is the sort of the third rung of that sort of support. And in the old days, it was those three that got together. Now we have others that are involved. Some of you talked about the interests of the government and its control, and how these individuals, the pioneers, were able to do what they did. Well, they were able to do what they did because there really wasn't much control in those days. Tom noted that control sort of came afterwards through the FDA itself, and prior to that, it was the IRBs at local hospitals. And as I sent out this morning, I sent out a note that if you look at issues related to the control in the older days, so the last 25 years, control was less stringent in countries outside the United States, away from the FDA. So a lot of companies took their medical device development, drug development to Europe. And once they obtained the safety and efficacy in those countries, they would get a CE mark. And then they were able to bring then that device back to the United States and use the information they obtained in Europe to sort of push them ahead. And the FDA was more likely to allow them to begin studies if they had the CE mark. Well, there recently, again, the paper I sent out, the article notes that the FDA is becoming less stringent, still probably fairly stringent, but less stringent, whereas the CE mark in Europe is becoming more stringent. So that may be something that will slow down the development of even newer devices. One of the components that we talk about, everybody wonders, well, what is the expectation? We assume as devices get better, there should be better expectations. I think what you have to look at, again, from a historical standpoint, is that the small amount of benefit that the patients had initially really was very, very helpful to them as patients. So for them, their expectations were very, very low. And so even though they didn't receive open set information, even though they did not have true understanding of speech in many settings, what they got was a heck of a lot better than what they did not have. So I think when you think about doing implantations, when you start out in your own practice, you really want to be sure that the patient has the expectations that are worthwhile. My first patient, as a comment, this was probably back in 1985, first nucleus multi-channel device. Patient was referred to us from a Kaiser hospital 3 months after the onset of sudden sensory nerve hearing loss bilaterally. So Dr. Luxford was all hot to trot. I had been doing implants before, single channel implants. I had done a few multi-channel devices, but this lady came in as an outside referral, so we implanted her. About 2 to 3 months after the surgery, she's on the phone, basically telling me I'm such a bad physician because, again, she's talking to me on the phone. I'm a bad physician because I did not restore her hearing. So in that particular case, it is important that not only you have the right expectation, but more importantly, the patient have the right expectation. So don't implant patients too early, because otherwise they will expect you to have normal hearing. And also maybe don't implant patients too late. Too late would suggest sometimes that you might expect them to do well. And some patients who have prelingual deafness and have long durations of hearing loss can function okay. They get more sound awareness, but they really don't end up with great auditory hearing through their implant if they have a long duration of deafness. So those are the kind of general themes you're going to be using as a team approach, and you better have the right expectation. When we look at the history, there's sort of paraphrasing here. Those who fail to learn from the mistakes of their predecessors are destined to repeat the mistakes. And those who learn from the success of their predecessors are destined to share in their success. So this course that Tom has put on is a great course. Tom does most of the work in the course. There are some of us who sort of help in one or two courses. The audiology component course is really excellent. The evaluation course, going through how you evaluate the patient, looking at auditory verbal therapy, that information is important. So if you look at all of these components that you're going to be going through over the next 14 weeks, really do the so-called pre-study review of the slides, look at some of the written material, and then you'll be better prepared to ask Tom and those who are giving the course questions that'll help you sort of balance out what you really want to learn. So this whole practice of history, what it went on with an implant, was a trial and error basis, because initially, there really wasn't much information as to what did occur. And realistically, even now, we don't really know what occurs with the electrical stimulation of that cochlea. So in those early days, there was more freedom to go ahead and try and fail, and then retry again. There was a difference in patient attitude. Patients were more willing to, quote, try things. Nowadays, patient attitude, some of them are willing to try, but they're also expecting more, so you got to be careful of the medical legal issues. Certainly when you deal with cancer and life or death issues, people are maybe more willing to try. So when you deal with what you're going to promise them, again, the trial and error may not be on your side as much as it was in the past. The FDA does control things. They control it through NIH grants, and so money for certain trials have to be done in such a way that it is more difficult to do them. So the companies are not as willing, say, to do as many of the things that you may want them to do as your own research. But one thing that companies have occurred is you'll see them as you start talking to the different representatives, you're going to find that there's a sort of cross-fertilization of ideas. That is, there may be many representatives that have been in all three companies, the three major companies right now that are in the United States. There is a fourth major company, Oticon, using the Neuralec device that is not quite in the United States as much as they would like to be. So when Oticon gets into the arena of cochlear implants with Neuralec, you'll probably have some of those individuals working for a fourth company. They seem to move from one area to the other. In thinking of history, as you develop your own careers, when you work with individuals, be observant, and you yourself be open to, say, to new ideas. In history, William House felt that the single channel device would provide the best benefit with the least amount of risk. He did use a multi-device. He was the first one to put in a multi-channel device. There was 5 electrodes that were slid into the cochlea. This was sort of firm wires that were bent and went all over the place. So it certainly was not soft surgery. But in those days, they were able to use something called a percutaneous device. So some of this talk as you go through these slides and as you read the literature, you want to be aware of there will be some terminology that used to be present and some terminology that is no longer present. So as far as the device itself, as an example, we had percutaneous, which means it was through the skin, or transcutaneous, which means it's the way it is now. The magnet holds the device over the internal receiver, and the device information and power sent across the skin. So if you think of a Baha, the true Baha, the abutment is a percutaneous abutment, whereas the Baha tract is more of a transcutaneous system. When you go again, be observant for ideas. If you're thinking of newer methods, the surgery, as we discussed and as Tom will go over later, the primary surgery, the surgery that's used the most often is the transmastoid facial recess approach to the cochlea. There are other, say, surgical approaches that have been used on the outside over time. I think many of them have sort of come and gone. First transcanal approach used by the Schindler group in San Francisco. Unfortunately, there were several extrusions of the wire electrode through the external ear canal skin. Some different approaches, the transmeatal approach, suprameatal approach, nowadays doesn't have direct access to the cochlea for maybe more of a soft surgery approach, a round window approach. So Be observant, be willing to accept new ideas, but also be willing to be critical of the actual approach that's used. And don't let your own, say, maybe lack of surgical skills influence you negatively towards a process that could be helpful to the patient. As we move along these different devices over time, you'll see that many of them, certainly now, they all look the same. So initially, two devices, the ones that were beginning to be used through the 1980s, were made out of medical grade ceramic. And the one device, the cochlear device, was made out of the titanium. Over time, even though the medical grade ceramic was noted to be bulletproof as thought by the different companies, you'll see that nowadays there are no ceramic devices. All three companies, in fact, even Neurolec, Oticon, all four companies are using titanium cases that can be hermetically sealed, and they are less responsive to direct stress, direct trauma. They are more willing to be able to get through the 2 to 10-year-old age group, especially of boys. When people talk about different approaches to the round window, soft surgery is now a major discussion point. That these are ideas, again, you want to think about. There's some patients that don't really require soft surgery. They have like blank audiograms, but even in those patients, you should think about, okay, how can I best approach this procedure? And always use the gentlest of techniques. The approach itself is going to be sometimes dictated by the kind of electrode you use. So there are certain electrodes that are more, say, bigger. They have insertion wires or insertion tubes that require a little bit of a more open round window approach, like an extended round window approach. There are others that are more of the slim, straight type electrodes that can be placed with a straight round window approach. So you want to be able to know what device you're using, and you want to be able to know what kind of electrode you're using. That'll help change the actual device that you have. In the past, as you know, there were certain devices that we talked about being not only the approach through the round window or the cochleostomy approach, but where was the electrode going to be? Was it going to be against the medalis? Was it going to be against the lateral wall? Was it going to be more mid-scala? All these terminology you've heard of in the past, going into the future, probably we're going to remain with more of a perimedallar approach and a mid-scala approach. The attempt is to try to stay away from the lateral wall as much as possible to lessen the trauma to the cochlea as the electrode advances through. So again, looking at that is going to be an issue for you. The early pioneers, they really weren't thinking of soft surgery. They were just thinking of how I was going to get this wire into the ear. Dr. Bill thought of soft surgery based upon the length of his electrode. So they started out with a smaller electrode, the 6mm electrode, single channel system. Other individuals, Graham Clark, thought of, well, maybe if I can go in deeper and have more stimulus to use, then I will be using this multi-channel, multi-electrode approach. There were some devices, initially the San Francisco device was a multi-electrode, but single channel stimulus. So there was a lot of things in terminology that were bantied around in the early days that really weren't quite accurate as to how they were, being presented. So it is important as you now think of this coming future and your years of practice. The marketing people are always going to sort of sway your ideas one way or the other. Right now, for marketing, all devices work essentially the same. There's really not much difference, even though each company feels that their device works much, much better. Some components of these different devices are that, some are more MRI compatible. Well, they've all tried to switch over to be MRI compatible. In the past, as I said, some were more, say, could be some more easily damaged, so they've all switched over to the titanium case. For other components, they now use hearing aids on the opposite side or hearing aids on the same side. So more people are looking at, stimulation of both ears. either with 2 implants or with 2 systems, or even stimulating one ear with both electrical and auditory stimulus. So as that goes along, you'll see different components that will be helpful to you in deciding what device you may choose. Unfortunately, you may not have much choice. Your hospital may choose what device they want to put in, and they may feel that they don't want to spend money for all 3 or 4 devices. So fortunately here at St. Vincent's, we can use or have access to 3 different devices, and we put them in based upon the patient's request, what they look at, what they decide. So sometimes the patient may decide on a particular device because they already have a hearing aid that it functions with that particular cochlear implant. But you may work in a hospital setting where the CFO of the hospital decides on which device you get to put in. So you may have only one device that they want to buy. You may be in a situation where, as a practicing physician, you can only put in the device that the audiologist that you work with is able to program that particular device. You should look at your own situations individually, but just be aware that historically and even now, there really isn't one device that is head and shoulders above the others. They all do very well, and they've all learned from each other. And I think that you should just keep moving forward with the use of these different devices. Going into now further terminology, we talked about the transcutaneous, percutaneous. Initially, there were even electrodes that were felt to be intracochlear, the ones we use now, and some people were afraid of the damage that might occur, so they were creating extracochlear electrodes. These extracochlear electrodes were used primarily by European physicians. England, Dr. Newick had your device. There were some others out of Germany. In some of those discussions for the patients, I think they found that the extracochlear device, though it could provide some sound awareness, it really didn't provide good electrical stimulation within the cochlea, and so it was not as good as direct electrical stimulation within the cochlea, especially when people moved on to the multi-channel, multi-electrode devices. In those early days, much of the stimulation, the method of internal processing, was developed. And most of that development came with the few individuals that worked with the percutaneous device. So Blake Wilson, another individual, Don Ennington out of Utah, worked with a percutaneous device. And so they were able to take patients and get the feedback from the patients as to how that stimulus would be successful. So they worked on the rate of stimulus, they worked on the wave forms of stimulation. All of these things were experimented and used, and so that's why over time there are different processing schemes that have occurred, and each individual manufacturer has used a different processing schemes as they felt that would be helpful for them. Some individuals got so enamored with intracochlear placement, they wanted to even break up to try to prevent the processing from, say, bleeding over to other electrodes, from one electrode to the other. So initially they thought that you should have systems that were more direct specific from one electrode to another, and they should be a bipolar stimulation. Right now, most implants are monopolar. That is, the electrical input goes to the electrode, and the ground electrode is somewhere on the implant itself or on a separate electrode wire that's outside, away from the ear. The monopolar was felt to maybe provide better stimulation across the whole range to be able to stimulate whatever vital elements might be still present. Again, we're not really sure what we stimulate. We think we're stimulating ganglion cells and maybe some neural elements, but no one's really sure. A terminology that even turned up, so-called pseudo-bipolar stimulation. So all these, again, older terminologies. Right now, the primary method of stimulation for ground is monopolar. And when you're using the electrodes, It provides stimulus. They try to, have these 8, 12, or 22 electrodes and provide stimulus within the cochlea. Each company does it a little different way. Each moment, though, you're probably stimulating no more than maybe 4 electrodes across that array. So that cuts down on this cross stimulation that might create effect. If you make your stimulation too focused, you will have trouble with electrical, probably burnout of maybe some of the neural cells. Tom will be discussing that later in more of the electrical stimulation talk. As I said, Dr. Billhouse initially started with a 6mm electrode. Well, over time, people learned from him. So some people learned that you were better off with multi-channel, longer electrode insertions. So some companies came in with the extra long insertion, the deep insertion. People have learned that maybe back off a little bit from that. Other people like Bruce Gantz learned, well, maybe the 6mm electrode is not that bad for creating further hearing loss. So in patients who have some good residual low tone hearing, but you want to use electrical stimulation for the high tones, he began the hybrid stimulation. So that was using electrical stimulation for high tone loss, which led to primarily a poor speech understanding, but they had good residual low tones, so that allowed them to have better appreciation of music. So that's where the electroacoustic stimulus came on board. And so it moved from a 6mm to a 10mm to finally the 16mm electrode that is now part of the hybrid cochlear implant. When you look at all these different devices that have come out, you realize that, say, stimulation is fine, but we're looking for the best result for the patient. And so, as we've changed expectations, sometimes not as many patients have come forward as we thought. So the hybrid device, I personally have never used a hybrid cochlear implant. I don't know whether any of you had experience with a hybrid. I don't know whether Thomas had experience with the hybrid, but not as many patients have come forward that sort of fit the dynamics of the hybrid implant. Unfortunately, when you use the hybrid, initially there may be some loss of hearing of the auditory component. The loss of the auditory component may happen even with stimulation, onset of stimulation. We do know that about 30–35% of patients after the first year have loss of that residual auditory component. So at that point, the question comes in, well, is it better that they had the 16mm electrode, or should they have had a routine 20, 24, or 28mm electrode placed? That is still up for discussion. There hasn't been a specific answer to that yet. Further changes in terminology. Now, this has become more apparent now, not in the early days of implantation, but now we talk about sequential and simultaneous. So initially, patients received one cochlear implant. Rarely did they receive a second cochlear implant. And rarely, if ever, was the second implant done simultaneous at the same time. As we've expanded the indications for implantation, the off ear, the ear that's not implanted, that ear oftentimes has some residual hearing. So in the old days of implantation, patients who were candidates for implantation audiologically were basically dead. They had dead ears on both sides. They were certainly profound. Now, as you know, patients can have severe to profound, and even patients that may have some moderate hearing loss in certain components of their audiogram. So when you're looking at patients who might choose, if you think about which side to choose for that single-sided device, assuming that you're going to have the ability to choose from either side. So it's not one side is not already using the hearing aid very well. You only have one choice, one ear to choose. The thing that you think of is you want to choose the ear that has a better hearing history, the ear that has a shorter duration of deafness, the ear that in the past has used the hearing aid at least most frequently. Again, using hearing aid means, but they're not getting any benefit from the use of that aid, but they've used the hearing aid most recently. A CT scan then shows the ear that has no malformation or savit chronic ear disease. And in the elderly, you're going to be looking at the ear that has the ear with the poor balance function. So in patients that are 55 years and older, we will do a VNG, caloric only, to make sure that the ear that we implant is not the ear with the remaining balance function. So in patients where you do, elderly patient, where you might say select or decide to do simultaneous cochlear implantation, be aware that it's possible that you could remove the balance function from the only remaining ear that has balance function. So that's why it's still in the adult patient important to do the VNG, because if only one ear has balance function, you probably should do sequential, if that. In other words, put the implant in the poor ear for it has poor balance function. And then you have a discussion with the patient that if they truly want a second implant, now it's not common, it's not typical that you can lose balance function with the cochlear implantation, especially with the soft surgery techniques, especially with maybe slim straight electrodes, but it is possible. And having loss of both ears, so-called dandy syndrome, is a typical thing for the patient to adjust to. For young patients that are born with loss of both function, they have no trouble. But to be an adult to lose all of a sudden both functions, it makes it very, very difficult to sort of get along in life. So because for the use of two ears has been sort of shown to be very helpful, so initially we had to go through, again, that trial and error period showing how much benefit that two ears provided. Initially, insurance companies would not provide coverage of bilateral implantation. Now, even Medicare may provide coverage of bilateral implantation if done supposedly in 2 different years. So let's like 2019, you do the right ear, you got to wait to 2020 before you can do the left ear if both ears are candidates for cochlear implant. I'm still not certain that that's truly accepted. Medicare has always shied away from bilateral cochlear implants. So I would look at your Medicare and get the true ruling before you do bilateral implants in a Medicare patient. As far as sequential, when to do a sequential device, most people would wait 6 months on one side, but wouldn't wait beyond 5 years. So similar to other patients and looking at duration of deafness, sometimes waiting too long can be too long. The patient has got so accustomed to using their one device on one ear, you basically have to force them to take that device off and to go without anything while they try to adjust to the use of the device in their second ear. It's important to note that adding the second ear does not automatically give you greater benefit. We think it does provide increased benefit, but it's not as if you've only got, say, 25% benefit from the first ear, that with a second ear, you're going to get another 75% benefit. It's more likely that most of the benefit you're going to get from cochlear implantation comes from the first ear, and the second ear provides maybe 20 to 25% just using a number benefit. It's not making things markedly better, it just makes them somewhat better. When we look at now implants, besides looking at the bilateral, sequential, or simultaneous, we now have unilateral cochlear implants for single-sided deafness. So what happened is over time, patients who had hearing loss received the cochlear implants for their hearing loss, and they would report that they received benefit in their tinnitus. So Dr. Williamhouse said, well, if you got benefit from tinnitus, how about I implant a couple of patients who have significant hearing loss and have tinnitus unilaterally? So he did a couple of patients, and the outcome really was not as good at that time. That's with a single channel device. So it sort of went by the wayside. Later, because again with multi-channel devices and many more patients noting improvement in tinnitus with the use of their cochlear implant. Again, in Europe, where it was not under control by the FDA, clinicians began looking at implanting patients who had unilateral tinnitus and severe loss, with treating that severe tinnitus with cochlear implants. In those patients who did have tinnitus, many of those patients said, hey, the cochlear implant does provide significant improvement in my tinnitus. Oh, and by the way, you know, my hearing's not so bad either. I can use the implant on this one side and use my normal ear or even an ear with a hearing aid on the other, even though I don't have a whole lot of loss. So because of the benefit gained by those tinnitus patients for the use of an implant for hearing and for single-sided deafness, then again, the physicians in Europe began to look at, study cochlear implantation for patients who had single-sided deafness, not necessarily patients who had tinnitus. So that has now come full circle where in the United States, there are many programs that are looking at implantation for single-sided deafness, where the other ear may be completely normal or have some hearing loss that is benefited through the use of a hearing aid. That's still not totally approved by the FDA, certainly not approved by Medicare. Medicare is sort of the, just in general, the provider of, if Medicare does approve something, then all the other insurance companies, Blue Cross, Blue Shield, etc., will usually approve it. Sometimes the other companies will approve things where Medicare does not. So you need to check with your different, say, centers. Also, it is somewhat state dependent. So like in California, almost nothing is covered. In the old days when we were first into implants, Dr. Charles Letzi in Kansas City and Dr. Bruce Gantz in Iowa, they could do things and get 100 patients when we in California were just trying to get 2 or 3 patients. So it's a total difference on what state you're from as to what is covered by the individuals. As far as implants, we talked about the 3 different companies, now 4 with Oticon, so using these newer devices, heavy devices, fairly expensive devices. Because there are certain countries where it's more difficult to, say, cover for the cost of the implant, low-cost implants have been in the market. So both in China, India, and Korea, these are markets where these scientists in those studies are trying to look at implants that are maybe less stringent, maybe just use 4 or 5 channels to stimulate rather than having the 8, the 12, or the 22, 16. Those different companies will probably take the information they have and begin to work with maybe some of the major companies to see if they could create this low cost. But right now, the companies are going into Korea, Japan, and China. Then there was the 4 major companies. So what the market will be for a low-cost cochlear implant, I don't know. There certainly are a significant number of patients in China and India that may have hearing loss that could benefit from a low-cost aid, sort of similar to now looking at patients who get hearing aids versus the PSAPs, the so-called hearing aid-like devices that are fairly inexpensive. Again, you look at what your expectations are. So for these patients, even the patient with a low-cost implant, hearing something is better than not hearing anything at all. In looking at the other indications, we expanded to patients with single-sided deafness. We've looked at, in the past, moving from initially kids that were 2 years and older, the benefit gain, that it dropped to 18 months and older. The benefit gain was worthwhile, so it went down to 1 year and older. So formally, right now, 1 year and older is the appropriate age for children receiving implants. However, if there is an appropriate reason, like certainly meningitis with closure of the cochlea with new bone growth, with individuals that have a known history of, say, family history of hearing loss, where you can be certain that there is a complete loss of hearing, then implantation is being done in children that are younger than 12 months of age. And many have been noted to be implanted between 6 and 12 months. A few surgeons have implanted even children maybe 4 or 5 months. There's some children, unfortunately, that get implanted because a surgeon can pound their chest and say, I implanted a child in utero. So the age, just because you're dropping the age, you want to make certain that you're implanting the appropriate patient. So for kids, it's difficult, certainly with the issue of auditory neuropathy. You're going to have an excellent talk about that later on in this 14-week session. You know, with autism, with development delays, you're never really certain sometimes as to what you have. So you want to be sure that you've given a good trial with hearing aids in the other patients that you know for certain that are not, again, either genetically associated or have issues with meningitis in those patients, probably a hearing aid trial is very worthwhile to be sure you're not putting an implant in a patient who definitely does not need it. So for some of these patients, for some physicians, that's why they talk about doing sequential implants in these younger patients. So if you want to implant 6, 7, 8 months of age, then wait for the 3 or 4 months to go by to see how that patient's doing with the implant, see what kind of responses they have. And then if you can determine that it's not auditory neuropathy, you can determine it's not autism, you can determine it's not other issues that might be affecting our inability to function on a audiogram behavioral test, then you can move on to the second side if you wish to put that in. Besides now single-sided deafness, we have two issues that are on the developmental field. Certainly there is the possibility of the total cochlear implant. Well, the thing that has held the total cochlear implant back is two issues. One, the microphone issue, and two, the battery issues. So battery technology is markedly changing. The microphone issue is another issue. Where to place it? There are implantable hearing aid companies that have no longer been on the market. The Envoy device, which had an implant that was, the microphone pickup was placed on the malleus or on the secure chain. So there are ways of perhaps overcoming the microphone issue, and maybe in time the battery issue will be overcome so patients can receive total cochlear implants. As you know, the issue of the external processor, the cosmetic issue, again, if you have nothing, then people were willing to carry, buses around, so to speak. So Dr. Chouard in France, his first device, the processor was carried around in a suitcase, like an attaché case, about 11 by 18 case. Then when we started in the United States, people had these on-the-body processors, and then they moved to on-the-head processors. And now two different companies are using devices that are just sort of a nubbin that sits over the actual magnet itself. So there's no part of the processor that sits on the ear. That does change where the microphone is, change where the pickup is. Whether that influences how the processor works, that's another story. But patients are quite happy with their on-the-head processors. How that changes in the future, we don't know. One thing that we do know, that when these newer devices come along, in thinking about the need for revision surgery, so if you have a device that battery is only going to last 10 years and you're putting it in a 1-year-old child, then over a 70 to 80-year lifetime, that individual is going to have 8 revision surgeries. So it's important to understand that every time you do a revision surgery, it's okay if the patient has a broken device, if there's some type of internal receiver, or if there's a medical problem, a bad infection. It's okay, in essence, to do revision surgery because the patient has nothing, they have no expectation. So you're removing their broken or diseased implant and replacing it. Now you're returning function. In patients who have a working device, and all you're thinking about doing is revision surgery to upgrade their device, that's another matter. You really need to think sort of strong and hard about, are you really going to benefit the child? So again, this comment about learning from experience from others, I had a patient, meningitis is their cause. We put in the electrode, got it in. It was working fine. Newer devices came out about 7, 8 years later. The mother was pushed for revising the device so the patient could have a different kind of processor, use less batteries, etc. And so nonchalant, in other words, myself, I agreed, I've done implants before, we can do this. So go in, and I got the device out, but I couldn't get the new device in. So I had to go out and tell the mother we couldn't put the device back. So we waited a few weeks to allow the child to recover from the anesthesia, and then I went back in on the other side. Now granted, remember, this patient had meningitis to start with, so I had already picked the better side to do the surgery on the first case. So now I'm going back in on the second side, the non-operated side, but it's the side that had the worst amount of maybe meningitis. So fortunately, I was able to get the device in. So everybody had a great sigh of relief. But that's my learning experience. It's not something that you young ones want to sort of repeat. So you can do revision surgery, especially if the device has failed. Be very careful about doing revision surgery for just upgrading the device. The next component we talked about is looking at one other thing I wanted to talk about. Newer forms of stimulation. So there's going to be new advances. There are going to be newer electrodes. There are going to be electrodes that are going to have steroid on them. There are going to be electrodes that may not even use the type of stimulation we're doing now. As you look at all these newer devices, be prepared to assess them, be prepared to use them. You may be the individual that's on the vanguard of looking at these new devices. If you're not, well, then be certain the people that did look at the new device have gotten something that really does work before you just jump on the bandwagon to use it. So take-home lesson, learn from the experiences of others. So we got 10 minutes left. Are there any questions now?
Name's Brandon Mangus. 2 questions. One was at the beginning of the lecture, you mentioned how things may be transitioning from Europe back to kind of America. I guess just a bigger question is why would Europe look into doing something like that, put them at a competitive disadvantage? And then my second question would be, you mentioned doing VNGs at a certain age of patients. And what age was that? Was that 55? I couldn't quite hear that.
So yes, Brandon, for that, the last point, we do caloric only VNG on patients that are 55 years and older to look for the side that may or may not be already damaged, and so therefore consider implanting the other side. As far as
perfect,
moving, as far as moving from Europe back to or Europe, let's say, having stricter rules and regulations, that's part of the European reason. I sent you an article. I listed it this morning. If you read that article, it talks about the changes. I think the FDA is looking at trying to reduce the regulatory effect, still maintain safety and efficacy, but trying to allow deregulation of some of the components that makes it more difficult for the United States companies to function. Whereas Europe, maybe they thought they were being used too much, maybe by other countries to work. I'm not sure how less stringent the rules were in the past, and I'm not sure how more stringent the rules are going to come in the future.
Thank you.
Dr. Luxford, I had a question. It's Elliot Kozin. I was just curious about your sort of personal experience with cochlear implants for single-sided deafness. Do you use it, almost exclusively for patients with tinnitus? Do you have any other indications that you've used it for? And maybe lastly, where do you see that going with sort of the recent FDA approval of it?
Okay, so I'll go from the back to the forward. So the FDA has approved implantation of single-sided deafness. However, Medicare has not approved it, and many insurance companies in California have not approved it. So in California, where I am, I've done 2 patients implantation for single-sided deafness, one for tinnitus and one for the hearing loss component. Both paid cash for their devices. The one patient who received implantation for tinnitus says it helps him, but he's really not too happy. The one who received implantation for hearing loss actually is very happy. So I think you need to look at, when you're dealing with tinnitus patients, as there was initially patients who had hearing loss, who got an implant for hearing problems and had improvement in hearing. They were very happy, and as a result, their tinnitus got better. Those patients who have tinnitus, who get an implant for tinnitus, sometimes are, quotes, a tinnitus patient. and they may not be happy no matter what you do for them.
Got it. Thank you.
Does that answer your question, Elliot?
Absolutely. Thank you.
Any
Well,
other?
I'd just add to that tinnitus is a tricky disorder to deal with. Anything that you can't measure is difficult to deal with. So I would stay very, keep at least one skeptical shoe on when you're walking through that maze. It's a very difficult group of patients. I remember as a resident, I was assigned to go to a meeting of the local American Tennis Association group in Denver. And I walked in and they were all there, and one by one, there was like a coffee before the meeting started, and they all walked up and introduced themselves to me and said, "Hello, I'm so-and-so, and I have tinnitus." And I kind of got the feeling that this was going to be a difficult topic to deal with as I went through my training. And it has been. It's been difficult. Keep in mind with single-sided deafness that you're no longer treating a deaf patient, you're treating a deaf ear. And although there may be benefit from that, the risk-benefit ratio gets edgier. When you're dealing with patients who have total deafness, the benefit to a successful cochlear implant is very large, and the risk, let's call the risk 100%, and the benefit, let's call that 50%. When you do it for single-sided deafness, the benefit instead of 50% might be considered to be 10% or 1/5 as good as Dr. Luxford, I think, said earlier. But the risk is still 100%. So the risk to benefit ratio is much smaller. And the other thing to keep in mind is the incentive for doing this. Can you imagine if you could quadruple the number of cochlear implants you sold as a manufacturer simply by supporting enough research to show that single-sided deafness deserves cochlear implantation, the incentive that's there. So as you can see, I'm a little skeptical about this. And although the research that's been done, a lot of it is very solid, and I personally know a number of patients who feel that it was worth the risk they took. Thanks, Bill.
Daniel, you have a question?
Yeah, I just wanted to pose one additional question about the difference between the monopolar and bipolar stimulation. I haven't heard a lot about the bipolar stimulation in the past. What were the results like with that? Was there any possibility of more music appreciation or greater selectivity of different frequencies?
So I think, Daniel, that Tom is probably going to go over the issue of bipolar and monopolar in one of his later talks. But if you think about a lot of things they've done throughout this whole life of from 1970s on till now has been on theory, right? Initially, it was thought that nothing was going to work, and even now we don't know how it works. But as people went forward, they would say, well, if we did this, if we stimulate more discreetly, if we only take this one little cell and stimulate that, then we're going to have better results. So that was this comment about bipolar came in. How can I only stimulate that one little cell?
Right.
Well, what they found out was that actually it was better if you just sort of stimulated everything. So that's why all devices are monopolar. In fact, the two devices have two monopolar stimulus, right? One's in the electrode, one's in the case. So just in case one breaks or something, you've got another area of a ground electrode. So I think it came across as we need to stimulate everything we can. If you think about, which I didn't really talk a lot of, is in malformed cases, in the cases with malformation, there really isn't a well-developed medialis with certain hair cells in certain spots, especially in the case with a common cavity. Common cavity is, that whatever's left is sort of on the outer wall. And yet many patients with common cavities can do fairly well. So fairly well is in, again, quotation marks. So as Tom just sort of mentioned for single-sided deafness, when you have nothing, anything is better than nothing.
Yeah.
So you have to look at these patients. You can't just lump them and say, well, because you weren't able to read and listen to me talking on the telephone, you're not doing well. Well, in their own mind, they may be doing great. Okay, like my first patient, who was a really sort of that successful lady. She, in her own mind, she was not successful, and I was the bad guy. But she would be listed as any kind of star patient. So in the old days, we used to talk about star patient. So she would be a star patient. Okay. There's Daniel Dottore. You have a question? Your hand is up.
Yes, thank you. I would like to ask you, in the case of a child with a single-side deafness with a congenital hearing loss, up to what age do you indicate CI in this patient?
Well, now you're getting into issues of duration of deafness and pre and postlingual or perilingual hearing loss. So you assume, based on what you described, the other ear is totally normal, and they have been receiving what you assume is cross stimulation from one side to the other. That's a different situation than if the patient is, say, let's say 20 at the onset of their single-sided deafness. So the side that you're implanting has had stimulation for 20 years on that side, besides whatever cross stimulation there is. So we have other patients who, for whatever reason, had a congenital loss, and then they over time developed total hearing loss in the other side. And the other side wasn't out completely, or for one reason they could have that other side implanted. So you implanted the side that had the congenital loss, but they had been hearing in their other ear for 25, 30 years. Some of those patients, and I can't give you like there's 100 of those kind of patients. Tom may have a few, but this particular example, that patient, even though they had cross stimulation from the other side for many years, when that patient used an implant on the side that was a congenital loss, he reacted as if it was a congenital loss ear. So in a patient who is born with a loss, early onset in life, so before 2 years of age, and now you're thinking of implanting them, say, more than 10 years later for single-sided deafness, I think that you're not going to get a very good result. And now that's going to go back to match what Tom said. You're trying to do something which may not really benefit them if the other ear is totally normal. Because as far as they know in their own mind, they've already adjusted the fact that they hear only out of one ear. And now you're going to try to get them stimulation in the ear that they've never heard from. So even though there's been cross stimulation of the auditory system, I don't think it's enough based upon the small amount of prior experience that I have that it would be worthwhile. So I would say if single-sided deafness now over the next 10, 15, 20 years became something that really was very, very good in all patients, then before I implanted the child with single-sided deafness, I would say, well, the duration of deafness has to be less than 1 or 2 years before I would implant that child. Tom, you have any final words?
Well, I just want to say thank you, Dr. Luxford, for another fine lecture.